afternoon, everyone. Good afternoon, sir. My topic is diverse presentation and eclectic outcomes in lens-induced glaucoma. Basically, lens-induced glaucoma can be classified into two types, as all other glaucomas are classified: open angle and angle closure glaucoma. In open angle glaucoma, there are phacolytic, lens particle, and phacoanaphylectic type of glaucomas. And in angle closure, phacomorphic, phacotopic, and pupillary block glaucoma. The phacolytic glaucoma, the term was coined by Flox, and Epstein was the person who described about the high molecular weight lens proteins which are involved in the pathogenesis of phacolytic glaucoma. Many a times in phacolytic glaucoma, what happens, the diminished vision is for a very long period. Maybe it can be of months or years prior to acute onset of pain, and the patient many times comes and says that he developed a sudden pain or a headache or redness in last 1 week for in last 3-4 days, but the process might be continued for a longer duration. Pathophysiology, basically there are two theories: macrophage theory and soluble lens protein theory. Macrophages, they get accumulated. Why? Because high molecular weight lens proteins are collected as the age grows. These high molecular weight lens proteins get accumulated into the lens cortex, and because of the accumulation, stretching of the lens capsule occurs, and there occurs micro defects in the lens capsules. Through those micro defects or micro openings in the lens capsule, these proteins leak into the anterior chamber and also into the vitreous cavity. The macrophages now engulf these high molecular weight lens proteins, and they obstruct the trabecular meshwork. Similarly here, high molecular lens proteins per se itself may go and obstruct the trabecular meshwork and ultimately block the aqueous outflow. And both the processes ultimately lead to acute rise of intraocular pressure. I'll present my three of my cases who came to me with the same, with some of the phacolytic glaucoma symptoms. First case is 64 years old male. His left eye was operated 8 years ago with his best corrected visual acuity of 6/9 and IOP was 11. Right eye, he came with acute sudden loss of vision with severe pain, redness, watering since last 4-5 days. It was not associated with any floater or colored halos or trauma or discharge. Findings in the right eye, in which the phacolytic attack was there, glaucomatous attack was there, vision was PL positive, PR was inaccurate in the temporal and superior quadrant, mild circumcorneal congestion, mild corneal edema with generalized haze, anterior chamber was full of white material giving a milky appearance, pupil was not at all visible, anterior chamber depth could not be assessed because of the hazy media, intraocular pressure in the right eye was unrecordably high, and digitally it was stony hard. B scan, we found that it was within normal limits. This was the patient. I did SICS in this case, small incision cataract surgery, as phacoemulsification. I couldn't see the capsule. I was not aware of the condition of the lens and zonules. So SICS was done, lens was removed, and simultaneously I did PI also. You can see in the inferior central image of the inferior line, and this was the condition of the eye after the surgery. After 1 week, the cornea was clear, pupil was round, pupil though it was mid-dilated and non-reacting, and after a month, I was perfectly okay. I did YAG capsulotomy because there was early posterior capsular opacity, and his best corrected visual acuity was 6/12 with pressure 14. Another patient, right eye was perfectly normal, left eye he had pain and redness since last 25 days associated with headache and recurrent vomiting. He was treated for some gastrointestinal diseases. It was misdiagnosed by a GP for last 3 weeks, and so the eye was not found to be the culprit, it was found something else, and his left eye had high intraocular pressure with which was 48 mm of mercury, and B scans was normal. Severe cells flare. Pupil was mid-dilated and pupil was faintly visible in this case with deep AC. This was the condition preoperatively. After I did phacoemulsification. This was the last photograph of giving subconjunctival injection after completing the phacoemulsification. I didn't either, do the PI in this case. First post-op day, the condition was this. Cornea was hazy with some microcystic bully and mild reaction was there. After 1 week, we can see that multiple bullies were there. Vision was 5/60 and intraocular pressure was still 20 millimeters of mercury. CD ratio could be seen, that was 0.4 and NRR was healthy. Third case was a female. She came with this condition, having some KPs and in her left eye. In this, minimal circumcorneal congestion was there, but she had the complaint for last 1 year and she ignored her complaint, and flare, thin reactionary membrane, mid-dilated non-reacting pupil was there, pressure was 52, and B scan showed some hint of optic atrophy. I did temporal SICS in this case. Pupil was round, regular, but not fully constricting, but pressure was 18, and after seeing, the CD ratio was 0.99. She couldn't gain vision. Another problem was there was a scleral necrosis in this case, because I did temporal SICS. On day 15th, I saw a scleral gutter and necrotic area there, and by the 30th day, it started resolving, and after 2 months, it was completely recovered without giving any scleral patch graft or any surgical intervention. It was automatically covered by lubricants and antibiotic drops. Steroids were stopped in this case. But she didn't gain good vision, as PR was inaccurate in this case and CD ratio was 0.9. So the outcome of my 3 cases were, in first case, there was good visual recovery because corneal health and retinal nerve fibers were preserved, as the surgery was done within 4 to 5 days. Second case, partial recovery of vision was there. Endothelium was compromised, but retinal nerve fibers were preserved, as the surgery was delayed for more than 3 weeks in this case. And in the third case, nil visual recovery was there. Cornea was normal, but retinal nerve fibers were lost, as raised IOP was almost for an year, as the patient ignored her symptoms. Take-home messages: patient can be confused for gastrointestinal or any other systemic diseases. Mostly patients one eye is having operated for long and they were satisfied with the one eye vision, so they ignored their other eye. Ultrasound is must to rule out any posterior segment growth like masquerade syndrome or retinal status, RD and all, and also to prognosticate the cases. Earlier the surgery performed, better is the result. IOP reduction followed by closed chamber surgery should be performed. IOP should be reduced after mannitol or anti-glaucoma medications. Inaccurate PR is not a contraindication for cataract surgery in phacolytic glaucomas, and trabeculectomy is not required in these cases. I did temporal SICS. Why? Because I wanted to preserve the superior part of the conjunctiva in case future trabeculectomy was required. And that is all. I'll rest my talk. Thank you so much.
Nice presentation. Any questions? Can I make a comment?
Pardon, sir?
I wish to make a comment.
Sure, sir.
This is my thinking, and in phacolytic glaucomas, we have to separate doing the CCC and decreasing the intralenticular pressure. The surgeon is sometimes under pressure to do the phaco. There are so many techniques described. We can do a YAG laser puncture, and puncture with a phaco needle, or a micro CCC, decrease the interlenticular pressure. There was no need of doing temporal CCC.
Sir, I couldn't see anything, but actually one of my case, I do not have my pictures of that case. What happened, I took the case, as I decompressed the anterior chamber, when all the secretions or all the collections were cleared off, the zonules were so lax that the whole of the lens came out through the dilated pupil. The lens was above the iris with lax zonule. So in that case, I managed to do the capsulotomy, can opener and envelope technique, put the lens. Next day patient was okay, slightly subluxation was there, but ultimately that lens dropped into the posterior segment. So I thought, if in case I do phaco without and pressure is generated during phaco, it may lax tissue may lax. it may go behind. That was the reason of doing temporal SICs in this case.
Very nice, ma'am. Another idea is one should always practice for the rainy day. For the rainy day means the facultative glaucoma. Like even in a normal cataract, one can just, if you have the time, just try doing a double CCC, 2 CCC. I have on record doing 5 CCCs in a single eye. So I was in the mood, I did it. I'm not praising myself. Just I'm suggesting, so that once you get such type of cataract, you know what is to be done, what suits you. Then you should know whether you want to do a CCC clockwise, you want to do anti-clockwise, you want to do with a needle, you want to do needle clockwise, you want to do needle anti-clockwise. Then you have your preferred pattern. You do it all the ways, needle clockwise, anti-clockwise, CCC clockwise, anti-clockwise with rexis, forceps. Then you find a way, then you do in normal eyes. Eventually one day you will find a difficult case and you will do easily. I do a small CCC, micro, then cut it and do with sodium hyaluronate. But it is a very good presentation.
Thank you. Thank
Nice presentation, ma'am. I would take this opportunity to ask the House on the relevance of PI in all these cases.
That was
Peripheral
slip
iridectomy.
of tongue, the YAG puncture of the lens capsule.
No, sir. Like peripheral iridectomy, surgical peripheral iridectomy in such cases.
In first case, I did surgical PI, but in other cases, I usually do not do that. Why? I just wanted to do a study also. Doing surgical PI in facultative, in long-standing, in early cases, but the study is still going on. It is not yet completed, so I cannot comment that. I just wanted to see the lowering of IOP after doing PI and without PI. This I wanted to do a study. That was the reason.